All right, 12:31 Eastern by my watch. Hello, everyone. I'm Lisa Juckett, an investigator for Learn's Didactic Core, and I'm very pleased to introduce today's presentation for year 3 of our series, Using Health Systems Research to Revolutionize Rehabilitation Care. Please note that if you would like to enable closed captions for this webinar, there are 2 options in the Zoom navigation bar. You can either select Show Captions if it's visible, or if it's not visible, you can select More to access the closed caption feature and then select Captions. You can then choose your preferred language. Today's webinar follows our fall lineup of events focused on engagement, leadership, and research management. You can view these and our other archived presentations using the link in the chat. Opening our spring lineup of events on health equity and justice, our speaker today is clinical health psychologist Dr. Eva Woodward. Dr. Woodward is a clinician researcher actively engaged in scholarship on how implementation science can improve health and healthcare equity across multiple health conditions for vulnerable populations such as racial minority, sexual and gender minority, and low-income individuals. Her research applies frameworks and methods at the intersection of health equity and implementation science to implement health psychology interventions or interventions in primary care settings. Dr. Woodward is a research investigator and clinical psychologist with the U.S. Department of Veterans Affairs in Little Rock, Arkansas. She's also an assistant professor in the Department of Psychiatry at the University of Arkansas for Medical Sciences and is affiliated faculty in the Center for Implementation Research. Dr. Woodward's talk will be followed by a Q&A session. We ask that you please enter your questions in the Q&A feature of Zoom so that we can address them once the talk concludes. After the presentation, we'll provide a link to an evaluation survey, and we'll also conduct a brief poll to learn more about participants. And take note, there will also be a poll during the middle of Dr. Woodward's talk as well. And finally, we will wrap up our time today by sharing some upcoming Learn events as well as funding opportunities. And with that, I am pleased to introduce Dr. Woodward, who has now come on camera, and she'll present 6 mindsets to promote health equity through implementation, practice, and science. Take it away, Dr. Woodward.
Thank you so much, Dr. Juckett. It is so great to be here with all of you. And in the Learn Network, I want to thank so much the Learn Network for inviting me. And I'm looking forward to both sharing with you today and also to discussing and hearing, and hopefully through Q&A have some lively discussion. So today I'll be talking to you about the area I've really dedicated my career to, which is about how to improve health equity and reduce healthcare disparities through implementation, practice, and science. And this is a really emerging field or niche within implementation science. There are some things and tools and mindsets that are pretty well established, and I'll share some of those with you. But there's also some things where there are new frontiers, where there's a lot of remaining questions, and I hope we get to talk about those as well. And in what I'll be sharing is really mindsets to approach this work, rather than, specific research findings. Some of the findings will come into play, but it's more about how to approach this, kind of a big picture talk, something for everybody. So let's dive in. Disclosures is that I'm an employee and consultant for the VA, the University of Arkansas for Medical Sciences and ViV Healthcare, and the views expressed in this presentation do not represent the federal government or the state of Arkansas. So this is just to kind of orient all of us. This is a belief that I have that really for equitable and just implementation of innovations, we must embrace complexity and realize that these are career-long, lifelong endeavors. To implement anything into clinical care or a community setting or even a school, or perhaps nursing homes or nursing facilities, it's hard to get anything from when we know it works to actually used in routine clinical practice. It's also hard to attend to when those innovations are delivered or received unjustly or unfairly, and then to do something to minimize that. And so it's difficult, it's complex, and this really kind of the dedication to this and your work will likely be ongoing. And I find that when I talk about equity and implementation science, it can be really overwhelming because it's so complex. So there's one really important question that I want to pose to you here at the start, which is, as I go through this, there's going to be a lot for you. There's going to be practical tools, examples of these mindsets. And I really want to ground you in thinking about what is the most elegant next step for you, which is a question that I learned from Adrienne Murray Brown in her book, Emergent Strategy. Be selfish with what I'm about to share with you. Figure out how to integrate it. As I go through it, think, how could this apply to me? And then start to drill down by the end of the talk, or maybe even the end of the day, or next week, about what's the most elegant next step for me. Just my next step, rather than tackling it all at once. Okay. So we've all come from a lot of places. You're probably on some version of a break, or you've got a lot of things going on. So let's take a chance to get present. As Dr. Juckett said, I'm with a psychologist. I'm a psychologist. You're with me. So hop along for this ride to just do a brief mindfulness exercise to kind of orient to being here and now. So go ahead and close any email browsers or chats, kind of put down any phones, just kind of, you joined here today for a reason, and I want to make sure you're able to get what you need. So if you are sitting, kind of get in a place where it's comfortable for you, but you won't fall asleep. And go ahead and close your eyes if you're comfortable. If you're not comfortable, close your eyes maybe 8/10 of the way where you can still kind of see out, or just stare at something neutral, not the screen, maybe a desktop or a wall. And wherever you are, as you inhale, just saying to yourself, breathing in, without trying to change your breath, noticing when you're breathing in. And when you're exhaling, saying to yourself, breathing out, noticing your exhale, noticing that in and out breathing pattern to yourself. Okay, one more cycle of breath. Okay, and just kind of wiggling as you need to, fluttering your eyes open, stretching if you need. We are present here together now. Okay. So sometimes people who need quality care the most are the least likely to receive it. And that has been documented for decades in the US and other places, and was even known as the inverse care law. So that's a healthcare disparity. And just to make sure we're clear on some terms, healthcare disparities inhibit health equity and justice, ultimately social justice and health justice. So there are health differences when you can have a difference in health outcomes between two groups, maybe based on a specific characteristic, but not all health differences are health disparities. Disparities are concerned with social injustice. So there's a health or a healthcare disparity in which one group who is suffering worse outcomes experiences societal disadvantage, historical or present day marginalization, and ultimately that inhibits health equity, which is the principle underlying a commitment to reduce and ultimately eliminate disparities in health and its determinants. So really the focus of this talk will be on healthcare disparities, and those specifically are unjust differences between groups in not due to their choice, not due to patient choice, in either access to an intervention, receipt of it, quality of it, or outcomes of those interventions. So let's check in together with a poll. I'd kind of like to know where in your field you are aware of healthcare disparities. So, and it could be it could be multiple, but the poll is a single choice. So select one that you are concerned about right now. Are there just healthcare disparities in structural access to an innovation? The innovation is the thing you are trying to implement. This, in your case, it might be a medicine, it might be a policy related to rehabilitation that is good practice. It might be a specific type of program, like a falls prevention program, for example. It could be an even more specific intervention, like you know, uh, getting nursing staff to do a certain type of check, or using multiple ways of communicating some information in some rounding. So that's the innovation. And it could be anything. It's the thing you want to get used more, that you want to reach more people. Now, is there a disparity in structural access to this? Like, it's out there, but few people even have a chance to get in line for it. Or is there a healthcare disparity in the receipt of that innovation? So people are less likely to be offered it. Like, it exists, it's in a facility, but people aren't getting offered it at equitable rates. Or maybe they are, and they're getting that innovation, but when it gets delivered, people receive it with worse fidelity or less patient-centeredness. Or are there disparities in the outcomes once it's implemented? So people are getting the intervention, but they're just not benefiting as much as others. Okay. So, and I'm sure that we've got people in your field where you experience, you know about healthcare disparity in all of these, but it looks like people are primarily noticing problems in structural access to the innovation. So it's not implemented at all, or in people are not receiving it. So they're not being offered it. And I have a feeling that over in a decade or two, we might see this pole shift where there's more structural access and receipt of innovations, but worse quality and outcomes. But that remains to be seen. Okay. So kind of have a sense of where we are. And also, if you don't know already, a good first step, an elegant next step for you would be to identify for whom those healthcare disparities exist in access or receipt or quality or outcomes. Now, this is the first mindset to introduce you to. Think about where on the continuum of research phases your study lies regarding first disparities and second, the implementation problem, and then match it to a suitable study design. So fortunately for us, the paradigms of implementation science and healthcare disparities research follow similar steps, which are basically to detect a problem or a gap, understand why it exists, and then reduce it. So at the top, you can see, the research to practice gap that we often see in implementation trying to fill. And then at the bottom, you can see the paradigm for the same steps for healthcare disparities. So you might be understanding the gap for implementation for the innovation you care about or you're working on, for a general population or certain settings, but maybe you don't actually know if there are any healthcare disparities there. So you're kind of understanding the gap for implementation, but you're also needing to detect where there's a disparity in healthcare delivery at the bottom. So your next study should have some design that allows you to detect a problem and then also go the next step in implementation to reduce the gap in implementation at the same time. There are study designs suggested for those different levels for healthcare disparities in implementation science. There is this paper that colleagues and I put out in 2017 now, and in it, in medical care, is a really helpful figure right here, figure 1, and it's a decision tree for people to incorporate implementation science study designs into healthcare disparities research. So you can kind of see there's questions that ask you, hey, is there a disparity? Yes or no? And yes, like, is there an evidence-based clinical innovation for the problem? Okay, yes, if there is, we're going on toward implementation. And then eventually, with more question and answer, it sort of gets you to some suggestions about what study design would be a great next step for you. So that's one thing that can help you at the outset when considering where is this in my field? What's the landscape here? And what would be my great next step for a study? Mindset number 2, giving everyone the same intervention or implementation strategy is not equitable, although it can be easier. Take a look at this visual from the Robert Wood Johnson Foundation. At the top, we have equality. So you can see there's 4 people and everyone has a bicycle, and the bicycles are all exactly the same. And you can see that the person who uses a wheelchair can't even get on this bicycle. There's a very tall, larger person using the bicycle but looks very uncomfortable. And there's a very small person who's kind of using the bicycle, but it's not even reaching the pedals. And I'm sure it will not go optimally for them. And at the bottom, we have equity. So this is when we have a bicycle, let me move out of the way here, that is suitable for everyone. So you can see the person who uses a wheelchair has a trike and they can use their hands to pedal. And there's a much smaller bicycle for the smaller person. Everyone has what they need. So this is an example of how interventions, but also implementation strategies can best be tailored to promote equity. That's in theory. That's one area where we don't have enough science to actually know that that's true. For implementation strategies, we do know that for interventions. There is a lot of evidence right now to suggest that tailoring, adapting implementation strategies to certain sites or settings works better than one-size-fits-all implementation strategies. And it is leading to a next question, which is, how does tailoring implementation strategies versus one-size-fits-all affect equity outcomes? We will see, or maybe you will see. So if you are going to adapt interventions to be better fits to implement before you start implementing, there is guidance on how to do that. So the Adapt It model from the world of HIV prevention, that's a great one. And there's in fact a video of it on Columbia's CTSA YouTube website, which is really kind of a description and a how-to from the developers. And there are other ways to do that. You can see an article abstract here of some work that my team and I led that uses CBPR intervention adaptations. CBPR is community-based participatory research to adapt an intervention prior to implementing it. So there's existing ways to adapt interventions. And then there are existing ways to document changes to implementation plans or strategies that may differ for different groups. So if you are wanting to track if you're saying, okay, let's tailor the implementation strategies as we go, and you want to document what changes. And there's some great tools for tracking. So one on the left, published by Rudd and colleagues, is a great tool for just tracking the strategies that are used. And those authors really reviewed a lot of literature on best practice, and they have a really nice supplemental file that's a Microsoft Excel document that's a tracking tool. And then if you want to instead track adaptations, a great tool on the right is the Frame IS, published by some really wonderful people, many of my colleagues in the VA, who devised it to track, who is recommending this change to this strategy? Why are we doing it? In what context? What mechanism do we expect it to affect? And so that's also a great way to document along in your study that you could add to even an existing study that you have right now. And there are great study designs that allow for for tailoring strategies as you go. So there's thoughtful delivery of strategies based on which sites need it most in smart designs or other adaptive trials, such as the one on the screen, led by Dr. Smith when they delivered an intervention in schools, and essentially based on predetermined criteria at multiple time points, they checked in on these criteria to say, hey, are these sites doing good or good enough or pretty badly? And based on that answer, then they changed the implementation strategies. And that was a way of tailoring to which sites needed it most. And it also preserves resources. So you're not giving a lot to the sites that just need a little. Okay, third mindset. Engaging end users or consumers affected by the health problem is the gold standard in health disparities research and probably should be in implementation science as well. So in your setting, this could be patients if you work in healthcare. This could be students if you're working in schools. This could be people who are incarcerated if you're working in criminal justice settings. So who is the end user? Who's the consumer that you want to receive this intervention? You want their health to get better. A lot of our community engaged research colleagues, public health colleagues know a lot about doing this in research. And there has been a lot that me and my team have learned from them to pull into implementation science. Preliminary studies suggest that engaging consumers in implementation does lead to better intervention fit and systems redesign that's more patient-centered, greater use of interventions, and actually improved health and patient health behaviors. So if you were one of those people at the poll at the beginning that said, people aren't receiving, there's a healthcare disparity in receipt of innovation, there's some evidence that engaging patients in that implementation practice or engaging your end user can increase the receipt of that or the uptake of that. And because groups of people have been caring for themselves for generations, they can and must care for the research in their communities. This is, increasingly important for any population, but especially communities that have been really actively excluded from health and research and healthcare, either working in it or receiving it. And it's showcased by this quote on the screen. And this is most notably applicable in the US among Indigenous or Native American communities. And that is one principle that underlies the importance of engaging consumers and community in implementation science. Fortunately, we have developed tools in my team on how to engage consumers who have been marginalized in implementation practice. A quote from a hospital middle manager that we spoke to said, "We would love to engage patients in implementing new services, but we just don't know how." And I can relate to that. So my team and I went and did a very intensive user-centered design process over 18 months and developed tools based on principles of community engagement. We talked to community organizers, we talked to various community members themselves, we talked to implementation experts, and really created a set of modular tools called Consumer Voice. The development of that is in the publication on your screen. And they're really a set of tools that are they're not prescriptive. They're not saying you have to do this in this order exactly this way. You can use them and say, hey, this is where I already know some of this, and I'm really looking for something more advanced. Or you could open it and say, I don't know anything about this, and there's stuff for the beginner there. So, the whole reason is that often when we're implementing something, it's very traditional, especially in healthcare at present, as to go talk to a lot of the stakeholders in the system, the hospital. It's kind of like making a mobile for a baby crib, installing it and hanging it over the baby's head and saying, I love this. This looks wonderful. But from the user perspective, the patient perspective, it's just butts. It's just butts. So, when you've received your own healthcare, you're going through that experience, and sometimes you think, did anyone think this through? Did anyone maybe consider what it would be like to be someone going through this experience? And the answer is yes, they did think it through, but oftentimes they have not thought it through for you. So the consumer experience is so important. And you can use consumer voice for free. It's generalizable to any setting. We developed them and are piloting them in the context of suicide prevention for veterans, but they are not specific to that group or problem. And they are publicly available. If you are a VA user, there is kind of a fancy version on a VA SharePoint. And if you're outside the VA, there is a version on a Google Drive that's simple, but in a lot of our user testing, people loved the Google Drive. And you are welcome to use those and study them. And that's one practical tool for you. Like I said, we are piloting consumer voice right now. This is a protocol of our pilot. So we'll have more data on this in 2 years. We're also, unfortunately, already renaming it. So taking suggestions on that. Would appreciate any suggestions. Some people have had an issue with the term consumer. And yeah, we're going to go through a systematic process to rename it, but I would love any ideas. Okay, here's the next mindset. Think upstream about what is causing inequities or disparities. So when you answered that question at the beginning, you were noting that there's a healthcare disparity in some group, or maybe multiple groups for the innovation that you care about. And so the first thing is to make sure you know for whom it exists and how bad it is, and is it a problem of structural access, receipt, quality, or outcomes. But then once you have detected that and you're trying to understand the disparity, and especially a disparity in implementation, you want to think about much more system level, community level, social level determinants that can interact and be linked and create structures of injustice, structures of inequity that can lead to really poor health. So, very classic social determinants examples where people are living and working, the unemployment rates in those areas, such as in rural areas, water and sanitation issues, such as in communities that are heavily disinvested. Close to me in the US is Jackson, Mississippi, and there has been significant disinvestment in their water system. When my family and I travel there, it's a real problem everyone's encountering. Their work environment. So is there safe working? Do they have paid leave for appointments? And even down to educational levels and access to specialists or experts in their area. And then they also, within those broader upstream factors, exist their social and community networks. And within that exist their own individual lifestyle factors and behaviors. And such as, how old they are and their physical health status as a result of that. And all of these interact. And so it's important to be accounting for those. And there are some great suggestions out there by other implementation scientists about how to think upstream. So one idea is to partner with outside health sectors or several sectors to implement something. So that, again, you're targeting multiple areas in the society and community level that end up having linkages that can cause inequities. Another example is to use system science and something called agent-based modeling approaches to capture multiple levels of cause and effect in a study. I haven't gotten to do this yet, and it's really on my list when my science is at the place where we could do this in the next 5 or 7 years. And also design research questions, data collection, analysis in ways that account for upstream factors. And one way to do that is to use an implementation science framework that accounts for health equity domains, such as the Health Equity Implementation Framework that my team and I developed. Or there's other theories of intersectionality or structural violence that could be helpful to account for those upstream factors. And also, when you are setting up a study, you can link social determinants of health and other upstream factors as moderators of for health outcomes or contributors to health outcomes, and set up some assessment and analysis to account for that process. Here's a recent example by a colleague of mine, Dr. Melissa Zielinski, also our colleague Nick Zoller, who's not pictured there. They are at the University of Arkansas for Medical Sciences. This is an example of an implementation science study in which they have partnered across sectors, and they're ultimately working on harm reduction in substance use and also in general for people who are incarcerated. And they're doing that by addressing many other things besides substance use, because we know that substance use and individual level behavior is affected by community networks, by social living working conditions, culture around it. So they have a grant from the US Bureau of Justice Assistance, and they are expanding a sheriff's reentry program. So people have been incarcerated and are now on parole or making their way out into the community. And here's some of the sectors they've partnered with to offer these cross-sector services to better address inequities. They have substance use counselors and 2 peer recovery support specialists. So these are like community health workers with lived experience. They also then offer medication-assisted treatment for people with opioid use disorder. So a pharmacy service offers that. They then offer housing upon release. So they address one of those social determinants. And then they also offer 12-week classes on trauma recovery. And so the psychology service offers that. So you've really got multiple services at multiple levels working with one population to reduce a really wicked, gnarly problem. Now, another mindset. As you progress, measure if it's working. Measure if you are moving toward equity and justice in your implementation studies. Ways to measure how implementation affected equity outcomes. There's a couple of frameworks to use as evaluation frameworks in designing studies. Or you could take something from it. If you already have a study that's going on, maybe there's something you could take from it and still look at with some of the data you have. There is an extension of REAIM to enhance sustainability by Shelton and colleagues, and that has an equity element. And then there is a really great conceptual framework at the bottom of equity-focused implementation research by Aslava Schmalbeck and colleagues. Now, there is a lot in that article at the bottom. And so I put a little note to see table 3 specifically for equity outcomes that you might consider. Because ultimately, what gets measured gets done. And you want to know how things affected equity and implementation. Now for the last mindset. Underlying all of the things I just said, one other important mindset for working on reducing disparities is to acknowledge and plan for uneven or imbalanced power, privilege, and oppression of yourself within your team and in the communities you work for, and also between your team and those communities. So there can be a lot of imbalanced power, which can lead to silence. It can lead to not fully understanding problems. It can lead to harmful behavior, even if well-intentioned. So our process of inquiry and knowledge production in science is inherently influenced by our lived experiences, by the systems in place, by those who came before us. And so therefore, our science is influenced by our and their biases. One of my colleagues, Dr. Corey Bradley, really talks about this a lot and has really made me think about how to incorporate this into my own work. And I will share some ideas with you. You know, at every step, like what questions are we asking? What are the potential solutions? What theories and strategies and, data collection are we using here? How each of these elements of a good research initiative and how we produce new science and new knowledge is really already influenced by who we are, where we live, the way we see the world. And that can be a strength, and it can also be limited. So it's important to have some critical self-reflection built into your research process all the way. There are many ways to do this. There are actually some self-assessments about certain cultures or general knowledge or skills in certain areas. You can do something informal, like do readings on cultural humility, cultural identity inventories, even something more casual like blog posts that are thought-provoking. You can get consultation from someone who's very skilled in this. Do reflective writing as an individual and or create team time to do that on field notes that have some element that prompts you to critically self-reflect on power dynamics. Your team can do culturally immersive experiences that are not voyeuristic, but ones in which you don't just observe, but you participate, that are related to populations you're studying. And even if you are a member of those populations, there are inherently power dynamics related also to the institutions to which we belong or we represent, among other things. And you can do these things privately with a peer on your team or with a supervisor or role model. And I have been trying different versions of these and experimenting with what works and what I find helpful, and have used almost all of these on the screen at this point. Some of them are still on my list. But one example that we just published you could read about was a paper called Learning to Practice Reflexivity while Engaging Communities in Implementation Science. My colleague Irene Abal and I published that as learners who were learning community engaged research, engaging communities in implementation science over a 3-year period. And we worked really actively on a reflexivity process to acknowledge our own positions, including our understanding and limits of how we viewed the phenomena and the people around us. And we described what we did, but also our perspective of, what value did it add? What was really challenging about it? To really, if you don't have experience with this, to read from someone else who was learning as well. Now, our colleagues in anthropology who know clinical ethnography are much more skilled in this and much more thoughtful in this, so you can also learn from them and borrow from their strengths. Now, to come back and recenter on kind of a big picture idea I'm putting out there. You've just heard a lot because it's hard and complex, remember? So we must embrace this complexity and realize that these are really career-long endeavors. And I'd like for you to think for, even 30 seconds right now. What is the most elegant next step for you? There are probably many things you heard that might be interesting, maybe some that weren't, that you're past or, aren't the right time. And I'm sure there was something there that could really take you and your team to another place, to another step. Take your work to a higher level of impact. What is the most elegant next step for you? Now, thank you so much for your attention. I'm excited to continue the conversation in the Q&A. I am on Twitter. I know that it's called X now, but I had a baby while that happened, and I'm not totally tracking all that yet. We are also recruiting postdoctoral fellows in Little Rock, Arkansas to come work with us and learn implementation science, focused on mostly behavioral health and substance use. So feel free to scan the QR code to read more about that if you know of anyone who might be a good fit.